Hello everyone, my name is Viraj Patel and today I'm going to present a case of Lana Mims, who is 62-year-old African-American female who was in the clinic today for her follow-up visit for blood pressure evaluation, and her chief complaint is uncontrolled blood pressure. History of present illness: she was in the clinic today for her follow-up appointment for blood pressure evaluation and overall medication management. She was in clinic 2 months ago, and at that time, statin therapy was initiated with atorvastatin 80 milligram tablet. Her blood pressure at the previous clinic visit was 161 over 87 and 164 over 83 on two consecutive measurements. She reports similar kind of measurement upon self-measurement via pharmacy blood pressure measuring machine. She was referred to pharmacy for management of her blood pressure and to evaluate overall preventative medication management. She reports of restricting dietary salt intake and tends to be more physically active by walking more and willing to pursue drug therapy for any and all of her condition. However, she is not ready to quit smoking at this time. Past medical history: she has hypertension, she has hyperlipidemia without history of myocardial infarction, PAD, or coronary artery diseases. Medication history: she is on MVI, POQD 30 tablets, atorvastatin 80 mg, POQD, Advil 200 mg as needed for her arthritis pain. She is allergic to penicillin. Her priority problem list include hypertension, next priority is hyperlipidemia, and list priority is arthritis pain. Social history: she smokes one pack of cigarette a day and she is not ready to quit at this time. Family history: her mother is deceased and she has dementia. Father is still alive with the history of hypertension. Assessment of disease and drug therapy. Patient's hypertension is not well controlled. Based on the patient history and most recent physical exam, patient has family history of hypertension as well as has genetic predisposition, which seems to be cause of the essential hypertension. Her consecutive blood pressure reading confirms that she is in stage 2 isolated systolic hypertension. She is also diagnosed with hyperlipidemia, which is proven by the fact of her lipid profile test, and statin therapy was initiated with atorvastatin 80 mg on September 22nd on 2017, which seems to be of appropriate intensity, and current lipid profile reading are within normal limits, and current 10-year ASCVD risk has been reduced to 17.5% from 27.8% since her last visit. We can further reduce this risk to 13.8% if our goal of 130 over 80 mmHg or BP goal is achieved. Patient seems to be motivated to control the blood pressure as she claims to cut down her daily salt intake and tends to be physically active more by walking more. However, she is not ready to quit smoking at this time, which seems to be contributing toward the worsening of her blood pressure. My goal of therapy is to achieve the target BP of less than 130 over 80 mmHg, which is supported by ACC guideline and many other guidelines. And my second goal is to reduce the risk of cardiovascular event and morbidity and mortality associated with the disease. Pharmacologic recommendation: I would recommend combination therapy of thiazide diuretic and calcium channel blocker since she has stage 2 type of hypertension. Thiazide and calcium channel blockers tends to have greater antihypertensive effect in older population, especially greater than 60 years of age, and patient coming from black racial background. Whereas calcium channel blocker has more antihypertensive effect in patients belonging to this racial background, and this population This population respond well to calcium channel blocker and thiazide combination than any other type of combination. However, same effect were observed in non-black population. This combination was also proven efficacious by accomplished trial. I would recommend chlorthalidone 25 mg POQD with food as initial dose, as it is preferred diuretic because of longer half-life and proven CVD risk reduction by all head trials. I would also add amlodipine 5 mg every day as the initial dose to the drug regime. I would also add aspirin 80 mg POQD-AM as prophylaxis in CVD, which is also supported by many guidelines study in a CVD risk reduction like American College of Chest Physician and ACC guidelines. Non-pharmacological recommendation, I would strongly recommend lifestyle modification. I would recommend aerobic exercise for at least 30 to 40 minutes for at least 4 times in a week, which would greatly beneficial for LDL reduction and BP reduction as well. I would also recommend DASH type of dietary pattern like diet rich in fruit and vegetable, low in saturated and total fat. I would recommend to reduce the daily salt intake as much as possible, less than 1500 mg per day. I would highly recommend patient to go for weight loss program and smoking cessation program as soon as possible. And I would also recommend patient to follow up in 1 month for blood pressure evaluation and dose adjustment. Patient safety and monitoring. Amlodipine may cause palpitation, peripheral edema, fatigue, headache, abdominal pain, nausea, and flushing. Improvement or maintenance of blood pressure is indicative of the efficacy. Monitor supine blood pressure weekly during the initial period of titration. Chlorthalidone should be taken in the morning with food. Patients should avoid alcohol while on the drug therapy, which may increase the hypotensive effect. This drug may cause hypotension, constipation, diarrhea, loss of appetite, nausea, vomiting, headache. Patients should avoid activity requiring coordination until the drug effects are realized, as drug may cause dizziness or blurred vision. Monitor electrolyte imbalance such as hypokalemia, hyponatremia, and hypomagnesemia. This drug may also cause dehydration, orthostatic hypotension. And I would also recommend to monitor overall compliance to the therapy to maximize the therapeutic effect. Thank you.